Hello, my dear candidates. Assalamu alaikum to all. How are you? So it's a noon time. Many candidates are busy on duty schedule. So it's actually acceptable because today's session candidates will be less participant due to schedule time, and many candidates message me for that reason. So hematology session all will be posted PDF and recording after that. So higher topics I'll discuss today that many candidates exam near, very near. That's why I'm starting soon. I'll not delay. First of all, I want to be sure is that my voice is clear, doctors.
Yes,
Yes,
ma'am.
ma'am, it's clear.
Yes, ma'am.
Yes, ma'am.
Yeah. So first of all, I want to tell a few topics like von Willebrand, hemophilia, okay, iron deficiency anemia along with thalassemia. These are the high topics for the SLE candidates or DHA/Hademich candidates and whatever the exam. Commonly from the DIC ITP, yes, they ask from the emergency medicine, mainly from the DIC question. Commonly APTT, PT, fibrinogen level. This way they ask a nice question, okay, broad question. ITP question along with the thrombocytopenia, they ask this way, and the management is direct. So these topics I will touch today. So I'm starting my session. Anemia. These are the high topics for the exam. We know it is microcytic and macrocytic. So microcytic anemia, dear candidates, so MCV will be low. It's a basic, we know, as we are practicing. And thalassemia, anemia of chronic disease, iron deficiency anemia, lead poisoning, sideroblastic anemia. So all are the microcytic. One point remember, celiac disease, this question, MOS candidates, it could be the megaloblastic. It's a two. In blood film, we got two types, hypersegmented and microsegmented. So hyper and micro, okay. So two type we can see. So it's a mixed varieties. But commonly for the celiac disease, MOH candidates remember, it is the macrocytic variety. So macrocytic variety, beta 12, B12 deficiency and folate deficiency. This type of picture we find out the vegetarian, vegetable and vegetarians, these kinds, and who are the taking more card like foods like milk, okay, other than protein. So the vegetarian, this kind of patient we find out that macrocytic anemia. Iron deficiency anemia. So see who are taking iron less, or a patient menorrhagia, female patient, okay, blood losing, it could be the GI malignancy, it could be a liver cirrhosis, it could be any kind of cirrhotic like CKD patient. They can't able to produce erythropoiesis, so erythropoietin deficiency, liver cirrhosis patient, esophageal varices patient, blood are losing, so iron deficiency anemia. In lab, we will find out decreased ferritin level, MCV level, hemoglobin level, and increased TIBC level and transferrin. So transferrin saturation, even if we do blood film examination or interpretation, who are working in medicine ward every day, chronic microcytic anemia, macrocytic anemia, we have to do peripheral blood film and we have to evaluate it by this way. If ferritin low, TIBC high, saturation, transferrin saturation high, so it's a iron deficiency anemia. Koilonychia present, my MOS candidates. So see, koilonychia, angular cheilitis, atrophic glossitis pallor. My dear heart candidates also, remember, koilonychia, angular cheilitis, atrophic glossitis pallor is the presentation of the iron deficiency anemia associated with Palmer-Vinson syndrome. So Palmer-Vinson syndrome, esophageal web will be the rupture and there is a chronic cases. So treatment will be the according to the causology, and we have to give iron supplementation. So see the blood film, recent many heart candidates entry recently their exam. For them, my high yield point, I already posted few images PDF and I'll post again. Images are very important for heart candidates. So yesterday one heart candidate was telling, ma'am, there's a lots of picture. Yes, you have to face those pictures. So microcytic anemia picture. So this is the microcytic variation, and you have to remember strongly microcytic variety, pictures and blood film. Iron deficiency anemia, okay. Iron deficiency anemia, though this is a brain trainer, just for discussion we can discuss what this said, okay. So this question will be discussed with me, Dr. Okay. In my panels, I can see there is many doctors. So Dr. Badhan is here, or Dr. Okay. If Dr. Badhan is not here, Dr. Sajma.
Yes, ma'am.
Read this question.
A 3-year-old has microcytic hypochromic anemia. He drinks mostly milk and eat very little solid food. What is the likely diagnosis? The diagnosis is iron deficiency anemia. As the picture is microcytic and hypochromic, and there
Yeah,
is history
excellent.
of milk intake,
My so milk interest, milk decrease, iron
iron
absorption, right?
absorption.
Even
Yes,
Dr. Sajma, my question: a 6 months baby started breastfeeding. Which type of anemia we will find out in 8 months or 9 months? Mom are very Mom are very tense regarding the lethargy. Baby are not well developing. So what kind of anemia we'll find out in this 8 month baby? After
iron
six
deficiency
months,
anemia.
yeah, I don't know cause what the mom started solid
Uh,
food, and after breastfeeding started stop, exclusive breastfeeding stop, and in this baby how you will manage, Dr. Sashma? This 8 months baby iron
will
deficiency. Mhm.
start giving iron rich foods, the foods that contain more iron content.
Yeah,
And if
excellent.
he's taking top milk like cow milk, then we'll ask to stop that also.
Yeah, cow milk. Actually, my question regarding this cow milk, if mom started cow milk, it also causing microcytic anemia because it decreases the absorption. So we have to stop cow milk, and it's a cow milk allergy, right, Dr. Sashma?
Yes, 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 ma'am.
Okay, thank you. Thank you, doctor. So, first question will be discussed with me, Dr. Somia.
Yes, ma'am.
Yeah.
20 years, college girl, mild weakness, HB is 5 gram, skipping meals to be slim, diagnosed as a severe iron deficiency anemia. You started oral iron, which is very much intolerated to her. What will you do? A. Convince and counsel her to take an on empty stomach. B. Give blood transfusion. C. IV iron. D. Will not give iron, only give vitamin B12 injection. As a mild weakness and HP is 5 and diagnosed severe iron deficiency anemia, ma'am, it's HB is low, it's B.
It's the first of all, Dr. Somia, a 20-year college girl, okay, and hemoglobin 5 gram, and skipping meals to be a slim. So what is that? It's the anorexia nervosa, right?
Ma'am.
Diagnosed as a severe iron deficiency anemia cause hemoglobin 5% difference. But so see, hemoglobin decrease, and you are a physician, you diagnose severe iron deficiency anemia, and you started oral, which is much intolerant. You see, you just try to listen. A patient come to your hospital, and I'm telling that I want to be very slim, and I'm not taking my meal, and you already given oral and iron, though you are seeing I am not symptomatic, I am don't have an exhaustion, but the blood film reveal blood
Ma'am, it's
film.
C, IV iron, because severe iron deficiency can't take the oral iron, which is very much intolerated. So C is the
Yeah,
option.
C is the option, not D.
If the
Because
patient is
D,
symptomatic, if the patient is
then,
symptomatic and HB is low, then blood
then,
transfusion.
yeah, excellent, excellent. That is the point I want to be listen from your side. If symptomatic, so see there, what is the point? Patient want to be sleep. Patient is skipping meal, right?
Yes,
So
ma'am.
we have to start it IV first to correlate the iron, to correct the iron, right?
Okay, ma'am. Thank you.
Yeah, thank you. Question 2 will be discussed with me, Dr. Fatima. Every question exam question. I will discuss today question and more information because it will be more conscious discussion today. So question 2, Dr. Fatima is here. If Dr. Fatima not able to talk, Dr. Rita Rani. Okay, Rita Rani, Fatima. Rita Rani able to talk or not? Okay, I can say unmuted the mic but not no voice. Is that so or my voice is clear? Mhm. Okay. Okay. So this question will be performed by Dr. Rita Rani. Your voice I can't hear. I am saying you tried to talk, but there is no voice from your side. Best to leave and again enter. It will be nice to you. Okay. So this question will be discussed with me, Dr. Anjana.
Hello. Yes, ma'am. Uh,
Dr. Anjana, yeah.
Good afternoon, ma'am. So, anemia
Good
with a
afternoon.
low MCV and a low reticulocyte. It is usually all except iron deficiency anemia, anemia of chronic disease, alpha thalassemia with 3 gene deleted, and none of the above. I think the answer is D, ma'am. None of the above.
So Dr. Anjana, low MCV, low reticulocyte, right? Your point. This is direct question, exam question. Low MCV, low reticulocyte, except iron deficiency anemia, it is low MCV, low reticulocyte. So okay.
Yes, ma'am.
Anemia of chronic disease. Anemia of chronic disease, low MCV, low reticulocyte, accepted. So it is not included. Alpha thalassemia, is it low reticulocyte or high reticulocyte?
Sorry, ma'am. It's high reticulocyte. Thalassemia has high
So,
reticulocyte.
so what is the answer?
It is C, alpha
Alpha.
thalassemia.
Yeah, excellent. So this is the way we have to do correct our answer, right?
Yes.
Yeah. Thank you. The question third will be discussed with me, Dr. Priscilla.
Yes, ma'am.
Yeah.
In iron deficiency anemia, which of the following is true? A. Serum binding capacity is decreased. B. Marrow iron stores are normal. C. Sideroblasts in the marrow are increased. D. Serum iron concentration is decreased. E. Teardrop cell blood flow. I think it's D. Serum iron concentration is decreased.
Excellent. That serum iron concentration will be decreased in iron deficiency anemia. But teardrop, no. Marrow iron stores will be normal. It's okay. But the thing is that in iron deficiency anemia, sometimes in CKD or malignancy, marrow resorption will be the except not normal. It could be the low or it could be the high according to the scenario. So it is not true. So only serum iron concentration will be decreased. It is the answer here. Thank you, doctor. So
Thank you.
my candidates perform very well. Three exam question I discussed. Question 2, alpha thalassemia trait, this recent exam question, low and high reticulocyte, don't be confused. And maximum candidates mark not above all. That like Dr. Anjana, none of the above. But it is not. So just I am discussing shortly that IV iron I already discussed with Dr. first candidate that IV iron I have to start it as patient is not symptomatic for the blood transfusion. So I have to start IV iron. For the Dr. Anjana's case, high reticulocyte will be the for alpha thalassemia trait. Serum iron concentration will be decreased in iron deficiency anemia. There is a lots of description I will not discuss after this PDF. All candidates must read this full description for the iron deficiency anemia. It will be very important for the exam. Megaloblastic anemia, my dear candidates, listen very carefully. The causology beta 12 deficiency. B12 deficiency, pernicious anemia, gastritomy, ileal recession, veganism, and chronic pancreatitis. Many candidates do wrong it. Chronic pancreatitis, they find out iron deficiency. How I don't know. Chronic pancreatitis celiac is exam question, MH candidates. Chronic pancreatitis always B12 deficiency. So don't be confused. Even this did exam question. Ileal recession, my MH candidates did exam question recently. By gastrectomy done recently, ileal recession done. What is the malabsorption? It's a B12 deficiency. Okay. So folic acid deficiency, dietary deficiency, gastrointestinal disorder, celiac, Crohn's disease. So celiac, folic, and B12. B12 both. So both. I already discussed. It could be the macro variant B12 and folic, but B12 and folic is more predominant. Crohn's disease, ileal recession done. It could be the B12 and folic acid. So don't be confused. MOH can is very important for the exam megaloblastic anemia. They commonly asking question from the megaloblastic anemia, alcoholism, pregnancy, jejunal recession, proximal jejunum is main site of the absorption. This is the ALA question they ask where folic acid mainly absorbs proximal jejunum is main site of the absorption. If you cut down this proximal jejunum, so it will cause folic acid deficiency. Medication methotrexate exam question. Exam question DHA had and every candidate. Methotrexate very important. Any medication associated with megaloblastic anemia, it is the methotrexate. Megaloblastic anemia, heart candidates, this question, this image you will find out and you will face the exam. My heart candidates. So remember very carefully hypersegmented neutrophilia and macrocytic anemia. I already given many PDF link. Just try to find out those images must to see heart candidates. Okay. Megaloblastic anemia, pins needle sensation exam question. Pins needle sensation in the limbs and hyperlobulated neutrophils are common in the B12 deficiency. Neutral tube defects are seen in infants born to women with folate deficiency. So, folate deficiency, if a female pregnant and we didn't give the supplementation, neural tube defect commonly baby will be the sufferer. And pins needle sensation, a patient vegetarian come to your hospital, pin needle sensation, you have to take the history and you have to identify the cause. It's a B12 deficiency cause patient are vegetarian. Okay. This way exam question all candidates paid question. Okay. So megaloblastic anemia treatment. So see, always check B12 level before treatment. Why? Folate must symptoms and allow neurological deficit to develop. So exam question hydroxycobalamin I have to give folic acid and you must correct B12 before folate. B12 first. So hydroxycobalamin first. So we have to remember B12 along with the folate and B12 level in acute lymphoblastic leukemia, folate deficiency. So we have to correct B12 first and then folate. So this way we have to remember the question what and how we'll correct our patient. B12 deficiency, patient history of gastritomy, my MOH candidate history of vegetarian diet, macrocytic anemia, pins needle sensation, peripheral loss of vibratory sense and position, cognitive changes. These are the presentation. These are the picture of the exam, and I have to diagnose the B12 deficiency. Picking the right as means megaloblastic anemia, MCV will be the high, but the thing is that along with the history, and we have to remember the poor diet, like of green vegetables, and we have to remember this is the megaloblastic anemia scenario. So the folate deficiency, okay, the who are the folate deficiency or B12 deficiency. So how we have to advise the patient to eat. What I will advise. So these are the advice that we have to take. We have to tell the more beef taking, broccoli, citrus food taking to supplementation or to improve the dietary habit. Dr. Ikra is here.
Yes, ma'am. Assalamu alaikum.
Walaikum salam. First question.
A young 32 years, pure vegetarian, busy businessman with history of frequently skipping of meals due to his daily busy work schedule. He presented with history of fatigue, occasional dyspnea on exertion and climbing stairs with weight loss of 2 kgs in 3 months. He has no history of fever or bleeding from any side. On examination, he has pallor and mild icterus. Rest of examination is essentially normal. His blood workup showed HB7, MCV 130, total WBC 3700, platelet is 100,000. Peripheral smear show hypersegmented neutrophils and macroovulocytes. What is the most likely diagnosis? Iron deficiency anemia, hemolytic anemia, megaloblastic anemia, and blood loss anemia. Ma'am, megaloblastic anemia. C option.
What are the clue here?
Ma'am, clue is MCV is high, 130. Secondly, peripheral smear shows hypersegmented neutrophils.
Okay, this is the megaloblastic anemia, and they will give a picture hypersegmented neutrophil, hypersegmented picture. My heart candidates. This is a very important exam question. Same to same exam question you will face in the exam. So must correct that is a many important clue. MCV high, hypersegmented. Even if they don't give this hypersegmented clue, they'll give the peripheral blood film smear. So you have to know this picture I already discussed before. And this is the megaloblastic anemia. Thank you, Dr. Ikra.
Thank you, ma'am.
Second question will be discussed with me, Dr. Monia Jaman able to talk with me? This is a DHA question.
Yeah. I can.
Yeah.
Okay.
Try to this question. Second question.
Second question. Just now, actually, I have joined. Oh, let me tell. Which of the following is the most commonly seen in the vitamin B12 deficiency? Peripheral neuropathy, dementia, posterior column damage. None of them. It should be peripheral neuropathy. That tingling sensation. It should be A.
Excellent. Dr. Monia Jaman, excellent. Though you joined late, I noticed also. But the thing is that you already know that vitamin B12 deficiency, patient present to your hospital with pin syndrome sensation. So this is the due to the B12 deficiency peripheral neuropathy. Excellent, doctor. Thank you, Apu.
Thank you.
So megaloblastic anemia question that you can discuss with me, very important. My heart can just see the picture and description you can read later. I'll discuss just more common topics. So hemolytic anemia, it could be the intrinsic cause, extrinsic cause. Intrinsic causes hereditary spherocytosis, sickle cell anemia, thalassemia, paroxysmal nocturnal hemorrhage, every topics exam related. Sickle cell anemia, every day they are asking. Thalassemia, paroxysmal nocturnal hemoglobin, my MOH candidate, GCSPD deficiency, my MOH candidates. These are the topics wise I just noticed. Extrinsic cause, autoimmune hemolytic anemia. So autoimmune hemolytic anemia, SCLE associated prosthetic heart valve, SCLE, and mycoplasma pneumoniae. These are the extrinsic causology. So hemolysis, it could be the intravascular, it could be the extravascular, decreased haptoglobulin, increased reticulocyte. Okay, it could be the extra, it could be the intra. So already I discussed in this question initially. Jaundice, increased bilirubin level mean hemolysis ongoing. In case LDH level increasing means it's the hemolysis ongoing. Positive chromosomes will be the positive for which reveal it's the hemolysis. So my dear candidates, this clue they'll give in the exam, that means hemolysis, autoimmune hemolytic anemia or anemia due to hemolysis, which will be the reveal, like that sickle cell they are giving, thalassemia they are giving, paroxysmal nocturnal hemoglobin they are giving. So according to the scenario, if LDH high, if Cumstus positive, even they didn't give Cumstus, they give this increased bilirubin, LDH high, reticulocyte count high, so it's a hemolysis. Hemolytic anemia is important to terms polychromasia. Polychromasia, poly which means chromasia means color, it signifies hemolytic anemia, so direct Cumstus will be the positive. So patient will present with you hospital lethargy, tiredness, increased fatigability. This is the picture already I discussed, rest MCV or normal MCV value due to the hemolysis. Okay. So MCV value is not important for me. My important point is the bilirubin LDH level. Hemolytic anemia, so which diagnostic purpose we have to do? We have to do direct antiglobulin test in which hemolysis reveal is. This is the point we have to remember strongly. MCV can be raised in immunologically mediated hemolytic anemia. My dear candidates, this chart is strongly remembered. Don't be confused by MCV level. Don't be. Hemolytic uremic syndrome TTP exam is a 4-star. My DHA had actually every candidate remember the differentiating point. TTP, though I just discussed, for thrombotic thrombocytopenic purpura, always there will be the neurological picture. In ITP, there are no neurological picture. Another is that gene mutation is the Adam S13. Adam S13 and history of the flu-like illness. And we have to manage this condition by plasmapheresis. Hemolytic uremic syndrome exam question, half candidates they will give the picture, lower limb picture, there will be the rash, hemolytic uremic syndrome. Predominantly after that bloody diarrhea or any kind of gastrointestinal infection. So the prodromal rash, lower limb or buttock, there will be the erythematous rash. So it is the hemolytic uremic syndrome. We have to give support by IV fluid, antihypertensive and dialysis. So hemolytic uremic syndrome, tired, and TTP is a pentad. What are the pentad? What are the tired? Tired are that hemolytic uremic syndrome will be there with the hemolysis, there will be the low platelet, there will be the rash. But TTP, there will be pentad, hemolysis there will be low platelet, but there's neurological picture along with fatigability. So triad and pentad. Remember plasmapheresis and supportive management according to the scenario. And we can't give antibiotic for the diarrhea or gastroenteritis in hemolytic uremic syndrome. Okay. First question will be discussed with me, Dr. Umer Shahazad.
Yes, ma'am.
Yeah.
Child with epistaxis, knee swelling, trachea, labs shows HP13, WBC count is 7800, platelets count is 17,000. His LFT is ultrasound abdomen and coagulation profile is normal. What is the most appropriate treatment? Methotrexate, steroid, IV immunoglobulins, and conservative. Ma'am,
Dr.
LFT is in
Umer,
the
what is the diagnosis, Dr. Umer?
ma'am, it's
Read again this scenario again and tell me, ma'am, these 3 points, and I am my diagnosis is this. You have to must to know what is the diagnosis and what is the management. Must. Exam question. Again read.
child with epistaxis, knee
Okay,
swelling.
epistaxis.
Yes,
Initially.
trachea,
Okay, petetia.
mm,
These are the
Lab shows
symptoms.
HB13, WBC count 7800, and
Okay,
platelets count
7,800. So it's normal. And platelet count,
it's decreased 70,000.
what is that?
When
What is that?
thrombocytopenia.
Thrombocytopenia means low platelet.
Yeah.
Then
Yes.
coagulation profile normals. What is the diagnosis?
It's ma'am hemolytic uremic syndrome.
Where is rash? Is there any rash?
Yes, ma'am. Take a in this scenario is given.
Only petechiae, but the hemolytic uremic syndrome, the erythema will be the lower limb and the buttock rash. It is not like that. Migratory erythema. No. That's petechiae. It's not erythema or there is no skin lesion. Petechiae bruise like if you healed or if you somehow traumatized or anyhow you hit by yourself, it will be the petechiae bruise like. It is not any rash. Because knee swelling means somehow child traumatized or by playing traumatized and knee becomes swollen. And epistasis. Epistasis is not picture of the hemolytic uremic syndrome. Dr. Umer. Here
Yes, ma'am.
platelet count low and picture epistasis petechiae. What is the diagnosis? Thrombocytopenia with or without bleeding.
Sorry, ma'am. I
If
can't
I
understand.
Okay, if I ask Dr. Umar, low platelet count, what is the diagnosis? Direct question. Low platelet count with normal coagulation profile. Low platelet, what is the
Yes, ma'am.
diagnosis? If I give the option ITP, hemophilia, and von Willebrand, what will be the answer? Only low platelet. There is no PT, APTT, all are normal. Option A, ITP, option B, hemophilia, option C, von Willebrand. What is your answer?
Uh,
What you will find out in ITP case? Tell me a scenario, ma'am. This is the ITP case. 1 point. Idiopathic thrombocytopenic purpura.
there will be, ma'am, thrombocytopenia.
And any history of the infection or may not be present, but only thrombocytopenia. But is there any coagulation profile disturbed or not? Yes or no? Like PT, APTT, is there any change? Yes or no? Like in hemophilia, PT level will be higher. Von Ilben will be the deficient, APTT will be higher. So in ITP, anyone will be higher PT, APTT level, yes or no?
No, ma'am. English profile.
So coagulation profile, normal. So what is the
Yes, ma'am.
diagnosis?
Ma'am, ITP, immune thrombocytopenia.
Immune thrombocytopenic purpura with bleeding tendency, right? With
Yes,
bleeding tendency, is a diagnosis is ITP. So Dr. Umar, what is the management? ITP case. Initially, ITP case you will find out and how you will manage. There is a bleeding
ma'am,
tendency. There is not severe, but the bleeding tendency, epithecia, swelling, epistasis,
ma'am, we give steroids to the patient.
steroid, right? This is the exam question, can't be wrong. Okay, Dr. Umar, clear now or no? Any
Yes,
question?
ma'am.
Any question?
Yes,
Method
ma'am.
exit, no. Immunoglobulin, no, because there is no severe bleeding. Even you have very difficulty to understand the diagnosis, but if this scenario given in exam, what you will mark, Dr. Umar? What you will mark?
Ma'am, steroids.
Steroid. If severe bleeding or crisis, we can give immunoglobulin or
Yes,
plasmapheresis. It's later part, right? Initially immunoglobulin, there is time to arrange plasmapheresis. Then immunoglobulin and plasmapheresis in crisis case, right, Dr. Umer?
Okay, ma'am.
Okay, thank you. I will discuss this question later after second question. Second question will be discussed with me, Dr. Second question is little bit not nice question, little bit tougher. Second question by Dr. Hira. You can try. It's not easy question, but direct question.
Yes, ma'am. Assalamu alaikum.
Walaikum salam.
Usually not seen in ITP, immune thrombocytopenic purpura, except splenomegaly, ANA positive, usually increased megakaryocytes in bone marrow, DCT positive. Um, Ma'am, this is asking the one which is present in ITP, right? Ma'am,
Yes,
it's
you are right. So
ma'am,
here
it's
said not seen in ITP, thrombocytopenia except. So here are all are wrong except one which is present.
ma'am. I think so. It might be C, megakaryocytes.
We can see in the ITP, right?
Yes, ma'am.
But splenomegaly not present in ITP case.
Yeah.
ANA positive not positive in ITP case. DCT is not positive in the
Positive.
ITP
Yes,
case,
ma'am.
right? But
Yes, ma'am.
megakaryocyte we can see in the ITP.
The
Excellent,
ITP
Nanda.
patient.
Yeah, thank you. Dr. Umesh Shahzad case, I feel it's a very nice, easy question MOH candidates, and even every candidate cause why they ask commonly. Even who planning for Oman exam, Qatar exam, every exam very easy and direct scenario. ITP case, Dr. Umar scenario, there is a thrombocytopenia there with or without bleeding. There is a knee swelling epistaxis. Prednisolone orally given for 3 to 4 weeks. Okay. Methotrexate is not answer. IV immunoglobulin is not answer because it is not life threatening. Okay. So Dr. Umar case, if this same scenario along with neurological presentation, it will be the TTP, but answer will be same. Its answer is the steroid. Management is steroid first. If you confuse by seeing headache confusion, don't be so. Platelet low, headache confusion means it's a TTP. It's not ITP. So my first initially I will give steroid first. All candidates clear or not?
Yes, ma'am, clear.
Thank you.
Yes,
Thank
ma'am.
you.
Clear.
Yeah. Dr. Hira's case, nicely Hira said, ma'am, in ITP case, splenomegaly never. And there is a megakaryocytes. So C, hepatosplenomegaly with normal examination of bone marrow increase megakaryocytes. So no hepatosplenomegaly, low lymphadenopathy, but in bone marrow in ITP case we can find out in megakaryocytes. This is the clinical part. Platelet disorder can broadly be classified into two groups, quantitative and qualitative. Quantitative means low platelet, means ITP. Qualitative means normal platelet but abnormal function, von Willebrand. Hematology question, you can carry more mark if you correct, like hemophilia, von Willebrand, ITP. These are the exam questions. So don't be confused. This PDF enough. I will post later. So ITP case, TTP case, I have to understand megakaryocyte, we will find out, but there will be no hepatosplenomegaly, there will be no DCT positive, there will be no ANA positive. ANA means what? Is autoimmune condition. We will find out the ANA ACLE, RA case and Sjogren's syndrome, but it is not like that. Okay, ANA is the autoimmune disease, it will be positive. My dear, every candidate's GCSPD deficiency is a pearl for the exam. Hemolytic crisis caused by favism, broad beans. This is exam question, patient taking favism or patient taking broad beans and come to hospital with hemolysis. So you have to stop first and you have to tell that you have to stop this taking. Exam question. Recently taking primaquine, traveling in the predominant area, now come to hospital with hemolysis. Nitrofurantoin sulfonamide also is also caused. Just remember from the pharmacology they ask. Jesus Perry deficiency is X-linked recessive disease common in male Mediterranean descent. Hemolysis jaundice will be there, and hinged body exam question they give what you will find out in the blood film. There's a hinged body and bite cell. Negative Coombs test, there is a hemolysis, but Coombs test negative, very important. This feature must to know, must to know. In case LDS due to hemolysis, we have to give blood transfusion, we have to stop the causative or factor, stress factor. Folic acid supplementation, avoid the trigger, and splenectomy is the, in ALA you'll find out, splenectomy is the best definitive management. First of all, we have to stop the causology, if primaquine, if favipiravir taking, and if there's any severe crisis, you can do blood transfusion. But later, we are given maximum treatment, and every steps we are already given, but patient already on crisis. Then later, last resort is the splenectomy. This MOS candidates and every candidate remember autosomal dominant disease, von Willebrand disease, hereditary spherocytosis, X-linked recessive hemophilia, and GSS-PD deficiency. From this way they ask what is the hemolytic, what is the autosomal dominant, what is the X-linked recessive, autosomal recessive, thalassemia, sickle cell anemia. Just strongly and blindly remember strongly. Dominant means 50% transfusion. Like a patient HFCM disease, autosomal dominant. So 50% it will transfer to the 50% child, and 50% will not be carrier. They will be the normal. So 50%. X-linked recessive 50% male will be the sufferer, or mother will be the recessive means mother will be the affected, but male will be the carrier. Recessive, X-linked recessive. Autosomal recessive means 25% will be carrier, 25% will be the affected, and 25% will be the normal. Just I want to draw a chart. Because they asked, and you have to remember the question. Male, female. So autosomal dominant male are the, somehow my patient, like a patient come to hospital with ADPKD, is autosomal recessive, but HFCM is autosomal dominant. But I am discussing with question wise or exam wise von Willebrand. It will be nice because exam question. Von Willebrand is the autosomal dominant. So male, somehow my patient male, he is sufferer, or he is dominantly this gene. His wife normal. There is no gene affected. Wife normal. So 50% will be the affected. Their 50% will be child will be the affected, means if you do this way, so X, Y, C, these are the affected. Same way, if you do so, same way 50% will be the affected. If you do calculation, okay. So 50% will be the affected and 50% will be the normal. This way, if you do calculation. Autosomal recessive now. Recessive means 25% will be affected means dominantly the sufferer. 25% will be the carrier. They will not present any symptom, but they carry the gene. Mean this person, if marry any kind of normal person or carrier person, so carrier will be the affected. But if marry normal patient or normal person, only all will be the carrier. So carrier will be the positive, but only one transmission gene will be the carrier. This way, 25% will be the carrier and 25% will be the sufferer and 25% will be the normal. Now, X-linked recessive hemophilia case, only male are the carrier and female are the sufferer. So, see, male are carrier, female are sufferer. So, if this gene transmitted, female will be the affected. But this same gene, if it transmitted, all male will be the carrier. This way, just remember, recessive, if it is X-linked, female will be the affected, male will be the carrier. If autosomal recessive, carrier, if a female carrier married a male carrier, 25% will be the affected, 25% will be the normal. That way we have to understand. Though this is the very depth, just to understand the basic, I discussed this question. So see, dominant disease present in all generation, but recessive skip the generation. Okay. This question will be discussed with me, Dr. Nandini Sharma.
Good evening, ma'am.
Good evening, doctor.
G6PD deficiency is an X-linked recessive disorder leading to inability to generate glutathione reductase and product red blood cells from oxidant stress. The most common oxidant stress is infection, dapsone, sulfur drugs, fava beans. Ma'am, it's infection.
It's infection. Excellent. First of all, why this infection? That they ask what? They ask inability to generate glutathione reductase and protect red blood cell from oxidant stress. So most common oxidative stress is infection, right?
Yes, ma'am.
Yeah, thank you. Second question will be discussed with me. Dr. Maha Umer discussed already. Dr. Maha Umer, yeah. Dr. Maha Umer. Still didn't discuss, right?
Yes, with glucose 6-phosphate dehydrogenase deficiency, best initial test is Hainsworth and White cell. GPT level is normal after acute hemolytic event. In case of hemolytic event in GPT deficient person, what is the recommended best time to repeat GPT level? A after 24 hours, B after 1 week, C after 2 weeks, D after 1 to 2 months. Ma'am, I don't know the answer. Best time to repeat.
First, GCSPD deficiency patient you done, and there's within a newly diagnosed case. Best initially you done hinge body and white cell, but it is GCSPD deficiency level become normal. But after acute hemolytic crisis, you have to wait till if you do assume to revert to settle and to repeat the GCSPD deficiency recommendation guideline to wait till 1 to 2 months, doctor. If it is a basic, it's not easy to remember. Just remember we have to wait 1 to 2 months. Okay.
Okay, ma'am.
Yeah, I will discuss. So after 1 to 2 months, you see glucose 6-phosphate dehydrogenase deficiency, X-linked recessive disorder leading to inability to generate glutathione reductase and protect the red cell from oxidant stress. So most common oxygen state is infection and other dapsone guanidine sulfur drugs. So it's the we have to these are the causology. Doctor, I was this is first case. So but most potent is a infection and other causes sulfur drug, pharmacology, nitrofurantoin can be caused, but the thing is that strong potential is the infection. Like Dr. Maha's case, we have to wait. Recommendation best time to repeat Jesus PD deficiency is 1 to 2 months. Just as strongly remember strongly. That is the point. Febrile transfusion reaction. Presentation will be the fever, rigor, hypertension, dizziness, chills, myalgia. Febrile febrile. It could be the hemolytic, non-hemolytic. If after transfusion patient started bleeding from any side, it's a hemolytic transfusion reaction. If there's only fever, chill, rigor, dyspnea, but no bleeding from the puncture side. If there's any bleeding from the puncture side, it's the hemolytic. If there's no bleeding but pain, it's the non-hemolytic transfusion reaction. Management for the pain, paracetamol, antihistamine, slow the transfusion rate and observe more frequently. And we have to stop the transfusion and we have to start the supportive management, oxygen and fluid support. Multiple myeloma exam scenario. Patient come to our hospital with CRAP, means what? Calcium, hypercalcemia, renal failure, anemia and bone pain. These are the triad or tetrad you can say. Investigation my DHA emerge hard candidates, urine protein electrophoresis, Ben Jones protein, serum protein electrophoresis, increased monoclonal immunoglobulin spike, X-ray punch out reticulation, blood film, rollers formation, bone marrow biopsy, abundant plasma cell. This every point is the exam question because patient come to my hospital with abdominal pain, calcium high, and there's a back pain. There's a anemia and the age is 45 or 50. So multiple myeloma and investigation will find out the punch out reticulation. They'll give the exam this X-ray and this is the scenario reveals a multiple myeloma. So we have to refer the patient or we have to correct those calcium level and we can give bisphosphonate. First thing, patient will be the over 60 years. Actually, you can remember it will be the more than 55. More than 55. That is the point and this is the remark. Bone pain, fatigue, weight loss. So initial investigation is the hemoglobin, calcium and ESR. Multiple myeloma investigation already I discussed. CRP will be the high, renal failure, creatine will be the high, calcium will be the high, and special does electrophoresis, fragility, light chain assay, free light chain assay, and establish the diagnosis by bone marrow biopsy and skeletal survey. Now hemophilia, exam scenario. Hemophilia, my dear candidates, remember, it is due to the A deficiency and B due to the NAN deficiency. Exact they ask the deficiency level. APTT in lab, APTT will be the high, I already discussed, and PT will be the normal. Von Willebrand factor will be the normal. Dr. Umer case, there will be the joint pain, which was the ITP, but for the hemophilia, there will be the intramuscular hemorrhage. But the Umer case, they said coagulation profile normal, but in hemophilia, APTT will be the high. Even if you discuss in von Willebrand deficiency, APTT, PT will be the deficient. So in hemophilia, we have to we have to supplement the factor 9. In hemophilia A, we have to supplement the factor 8. Hemarthrosis. This question will be discussed with me, Dr. Nandini Sharma.
Yes, ma'am. Good evening, ma'am. Pancytopenia, iron deficiency anemia, thrombosis, episodic dark urine is classically seen in the following. aplastic anemia, paroxysmal nocturnal hemoglobinuria, myelodysplastic syndrome, or acute leukemia. Ma'am, it's paroxysmal nocturnal hemoglobinuria.
Excellent. What is the cause? Why it is PNH? Why not A? Why not C? Why not D?
Ma'am, because the clue they
Hmm?
have given dark urine
Excellent.
and
And thrombosis.
thrombosis.
And
Yes.
thrombotic phase and pancytopenia. Myelodysplastic syndrome, there is no myelofibrosis, there is no myelodysplasia. Aplastic anemia, yes, pancytopenia, it is the clue, but in aplastic anemia, not in thrombosis or not in dark urine. This is where Dr. Maha nicely discussed. Thank you, Dr. Maha.
Thank you, ma'am.
So PNS, paroxysmal nocturnal hemoglobinuria. So Dr. Nandini nicely discussed. Dr. Nandini, first of all, Dr. Nandini said that paroxysmal nocturnal hemoglobinuria, CD55, this protein known decay accelerated factor found that surface RBCs protect them the complement mediated hemolysis. So remember, paroxysmal nocturnal hemoglobinuria is a deficiency of glycolized phosphatidylsterol anchor molecule deficiency. This word MOH candidate CD55-59 deficiency. Just remember this way. Nandini next to discuss that PNH, there will be the iron deficiency anemia, there will be the dark urine, there's a venous thrombosis. So all goes towards thrombosis. It's a PNH. For most accurate diagnosis, we have to remember that CD55-59 we have to do to see the cytometry test, and it will be the deficient, and we have to treat initially by prednisolone, and allogenic bone marrow transplant is curative. So if they ask hemolysis thrombosis ongoing, we can use eculizumab or complement inhibitor. Initially, you can give prednisolone. Actually, my point of view, as I am a mentor, always remember for exam they don't ask regarding this complement inhibitor or allogenic bone marrow transplantation. Initially, how will manage? You are doctor of emergency, patient come to your hospital this way. We have to give initially prednisolone. This is the exam. That's why I'm emphasizing. Remember prednisolone first and the hemolysis, ITP, TTP, PNH, paroxysmal hemoglobinuria. We have to give first prednisolone. Von Willebrand disease, deficiency or abnormal functioning of von Willebrand factor. So, which is necessary for platelet plaque formation and presenting degradation of factor 8. Von Willebrand factor, there will be the tear, there will be the bleeding, von Willebrand disease. So, see, platelet can't form the plaque, so it causes for the hemostasis, so it causes bleeding. Bleeding from the mucosa, easy bruising, bleeding gums, Dr. Umercase. So normal APTT, normal PTINR, but bleeding time will be the high. Just only one point, Dr. Umercase, the coagulation profile was normal. That is the point. Coagulation profile normal means it's the ITP or TTP according to the scenery. But if they said PT, APTT, bleeding time, the bleeding time will be the higher in von Willebrand disease. Tranexamic acid initially you have to give, and desmopressin release von Willebrand factor from the endothelium. First question will be discussed with me, Dr. Shamim Shahid. It's Mehwis maybe.
Yes, ma'am. Assalamu alaikum.
Alaikum salam.
A 15-year-old girl is referred to hematology. She started having periods 3 years ago, which have always been very heavy and prolonged. Unfortunately, the menorrhagia has responded poorly to the trials of tranexamic acid and the combined oral contraceptive pills. Blood test shows the following. HP is 10.3, platelet count 239, WBC 6.5, PT 12.9 seconds, and APTT 37 seconds. What is the most likely diagnosis? Hemophilia B, disseminated intravascular coagulation. Hemophilia A, idiopathic thrombocytopenic purpura, and von Willebrand disease.
Dr. Mehis, your case is not easy to understand. First of all, 2 point here for your
Yes,
diagnosis. Okay. So
yes,
for
ma'am.
2 point here for your diagnosis, first of all, you have to do interpretation. And what they said? They said patient come to your hospital with prolonged and heavy bleeding. This is the point. Prolonged and heavy bleeding, right?
Yes,
The
ma'am.
patient prolonged and heavy bleeding, it could be any, hemophilia B, A, any. But the thing is that APTT slightly bit or mildly higher. It's a 37. Our
Yes, ma'am.
APTT level is not 37, it's around 30 or 25 actually, or
Yes,
15
ma'am.
like it's according to the lab. They'll give the value, APTT PT value. So commonly in our practice we will find out the APTT value, sometimes it could be 20 or 15 like that, but it is 37, mildly elevated. Okay, APT
Yes,
high.
yes,
PT
ma'am.
12, okay, it's acceptable, it's a normal range. So according to scenario, what would be the answer? Menorrhagia, prolonged bleeding.
Ma'am, it could be, I'm actually confused between hemophilia B and hemophilia B, ma'am.
You confused with APTT level. That's
Yes,
why
ma'am.
you are
Yes.
telling beta hemophilia. But if I say prolonged bleeding, I just discussed with this
Ma'am,
question.
then von Willebrand disease.
But it's a von Willebrand. This is not easy. I said already.
Yes, ma'am.
Prolonged bleeding, when they said it goes towards von Willebrand for APTT high, it's a mild, it's not so severe for the hemophilia B, and they definitely in exam definitely say 9 deficiency or 8 deficiency, okay, in hemophilia AB, but there's nothing they given, only APTT higher they given, but only 1 point is strongly they heavy bleeding, so its answer is von Willebrand disease. Okay.
Okay, ma'am. Thank you.
Next question, yeah, thank you. Next question will be discussed with me, Dr. Priscilla Pushpam.
Yes, ma'am. A 34-year-old man who is known to have type 1 von Willebrand disease asks for advice. He is due to have a tooth extracted at the dentist next week. Which one of the following is the most appropriate management to reduce the risk of bleeding? Mefenamic acid, vitamin K, desmopressin, factor 8 concentrate, or factor 7 concentrate. Most appropriate management. Is it desmopressin?
It's the desmopressin. Yeah. Answer desmopressin. You are right. Most appropriate management is desmopressin for von Willebrand disease. Okay. Because we are truth extracted dentist next to our, if they said initially we give mefenamic acid, but best always desmopressin. Thank you, doctor. Coombs test is a hemolytic test that we have to see is there any hemolysis present or not. So direct Coombs test, direct antiglobulin test, direct antibody. In RBC surveys, we have to do diagnosis in autoimmune hemolytic anemia. So indirect Coombs test detect antibody in the serum, cross matching in the bladder, and the antenatal antibody screening we can do indirect Coombs test. Every exam candidates, DIC is the high yield topic. Even no exam except DIC or pulmonary embolism. Everyone face this question in exam. So DIC, widespread activation of the coagulation, widespread activation of the coagulation cascade result in decreased clotting factor. PTAPTT will be the high. Blood clots different organ in the end of the bleeding. Sepsis, major trauma, cancer, presentation of the petechiae bleeding, GIT, they give emergency. In ICU patient in embolism, and you find out PT APTT will be the high, fibrin degradation will be the high, and platelet and fibrinogen. Fibrin degradation is the D dimer is high, but fibrinogen will be the low. So PT, APTT, fibrinogen is a low, so it's a DIC. They ask how you will manage, so translation is the plus fresh plasma, and we have to treat underlying cause and supportive management. Exam full scenario exam question. Either the lab they ask the what is the diagnosis and management. So hemophilia, this is the higher topic. So we have to understand this hemophilia APTT will be the high. Just the doctor confused with Dr. Mehis. Von Willebrand also APTT will be high. So Dr. Mehis, don't be confused. In von Willebrand APTT also high, bleeding time also high. Okay, even they didn't give the bleeding time. So hemophilia commonly bleeding in the joint. Okay, so DIC, PT, APT bleeding time, D dimer will be the high, and ITP the platelet count will be the low, and history of upper respiratory tract infection. Okay. Hereditary spherocytosis, my dear, heart candy is very important for the exam. Just remember that they will give this blood film picture. Hereditary spherocytosis, there will be hemolytic anemia, it is autosomal dominant picture, defeat in the RBC, structure of the pattern, there is spherocytosis, and patient present in your hospital with splenomegaly, gallstone is pigmented gallstone, and whole gel body will be the positive and positive osmotic fragility test, and parvovirus B90 aplastic crisis. Aplastic crisis will be there. So folate supplementation and definitive management is the splenectomy. Hereditary spherocytosis is very important exam scenario. Sickle cell anemia, sickle cell crisis, aplastic sickle cell anemia, or sickle cell disease, we have to know very well. It's autosomal recessive disorder. So it's a vaso-occlusive crisis, triggering infection, and there's ischemia pain. There is a splenomegaly will be there, and we have to do the splenectomy. And the patient acute respiratory chest syndrome or acute respiratory distress syndrome. Patient come to your hospital with distress, cough, tachypnea, tachycardia, hypoxia, fever, vaso-occlusion case, aplastic crisis, parvovirus B90 infection, decreased reticulocyte. So blood smear, high reticulocyte, sickles, RBC, hemoglobin electrophoresis for the diagnosis. We have to give folic acid deficiency, we have to give folic acid, we have to do the blood transfusion, we have to give penicillin prophylaxis, and avoid situation like infection or any food or any drug or any dehydration you have to avoid for the sickle cell anemia. First question will be discussed with me, Dr. Hira Abrar.
Yes, ma'am. HP electrophoresis done for young adult male patient shows HP 58%, HBS 35%, HbA2 2%, HbF 5%. What is the most likely diagnosis? Thalassemia minor, thalassemia major, sickle cell trait, sickle cell anemia, sickle cell thalassemia. HP electrophoresis done, young adult male, HbA 58%, HbF 5%, and HbA 2%, HbS 35%. Ma'am, it's not sickle cell anemia. It's not sickle cell trait.
Why not trait? Because ACE is 35%, then A2 and F. So ACE is higher. Thalassemia minor is excluded, there's A2, A value is lower, right?
Yes, ma'am. Yes, ma'am.
For the trait, ACE percentage is 35%. Okay, but not is anemia or sickle cell thalassemia.
Yes, ma'am.
Okay, I'll discuss this percentage later. Second question, just I want to discuss shortly. Then first question will be discussed. Dr. Anjana, second case.
Yes, ma'am. In which of the following condition is regular IVIG replacement therapy an absolute indication? AIDS. Option B is chronic granulomatous disease, IgG2 subclass deficiency, severe combined immunodeficiency, none of the above. So first of all, option A is ruled out. In AIDS, we don't give IVIG. Then chronic granulomatous disease. Ma'am, I think severe combined immunodeficiency.
Yeah, cause we have to give IV immunoglobulin, intravenous immunoglobulin in severe combined immunodeficiency case called chronic granulomatous, no need. IgG2 subclass deficiency, no need. AIDS, no need. So its answer is D. Thank you, Dr.
Yes.
Anjana. So Dr. Hira case sickle cell trait, just she's little bit confused because why the trait is there is the percentage. The hemoglobin S percentage was 35%. It is trait option. So what is the difference sickle cell disease and trait? sickle cell trait inherit gene of normal hemoglobin and one gene sickle cell hemoglobin from their parents. So they have a gene which is the trait do not have any medical problem, only trait. So sickle cell disease, two gene will be there, two gene. Trait, there is one gene either from the mom or from the father, or sickle cell disease, both gene will be there. So sickle cell disease and sickle cell traits, remember, symptomatically active in the disease, not trait. Trait will not be symptomatically present. So only disease will be symptomatic sufferer or symptomatically affected. So trait percentage will be the 20 to 40%. Here, Dr. Hirar case was 35%. So it's straight. For the disease, see the percentage. They will say for the disease means affected or suffer, it will be the 80 to 90%. So when this percentage we have to remember strongly, if they say hemoglobin S percentage 75%, it's 85%. So what is it trait or disease? So Dr. Hira. Dr. Hira?
65%, right? Yes, ma'am. Yes,
No,
ma'am. I'm
I
listening.
said no. I said hemoglobin S. I say this question I am saying is a 85%. What is the answer?
That's a disease.
It's a disease. So what is the answer? It's a thalassemia, sickle cell, thalassemia, sickle cell disease. So if it is said, if I say it's a 40%, so what is that?
Trait.
It's a trait, right?
Yes, ma'am.
It's a trait.
Yes,
So it's
ma'am.
a suffer and it's a trait is not sufferer or present any disease, but diseases are the show the disease complication. Okay, thank you. Tumor
Thank
lysis
you so much.
syndrome very important.
Mm.
Massive cell death. Hello, any question from anyone? Okay. Massive cell death in chemotherapy, hyperkalemia, hyperphosphatemia, hyperuricemia, hypocalcemia. So all are hyper except calcium. Excessive phosphate cause precipitation of calcium in the kidney, which cause hypocalcemia and renal failure. So we have to manage IV fluid diuresis, raspberry exam question. Raspberry you have to give hemodialysis if kidney failure, allopurinol for the prevention. So tumor lysis, we have to manage this way. Thalassemia, beta thalassemia major minor this way. Patient with alpha thalassemia major usually die in uterus. So alpha thalassemia usually die, but thalassemia trait are usually asymptomatic, macrocytic variety. Major present anemia in childhood, failure to thrive. So major present in hospital with failure to thrive, anemia, and extramedullary hematopoiesis. Okay. So major absent synthesis of beta chain of hemoglobin. Okay, so severe hemolytic anemia, there's a frontal bossing, prominent facial bones, dental malocclusion, hepatosplenomegaly, iron overloaded due to blood transfusion. You are giving the blood, and iron will be overloaded, which causes hemochromatosis. In lab, the hemoglobin A2 will be the higher. In electrophoresis, microcytic anemia, saturation and ferritin will be the elevated, and there is a hair on and appearance in the X-ray. So exam, they ask the treatment, lifelong blood transfusion. If there is a hemochromatosis or iron overload, we can do iron chirration. Acute leukemia, my dear candidates, my dear heart cancer or body, ALL, anemia, recurrent infection, bleeding, bone marrow biopsy, numerous lymphoblasts in AML. There will be the in adult, okay, fatigue, gingivitis, bleeding, and or road presence. So AML or road, and in ALL only numerous lymphoblasts. This way we have to remember the question, and the ALL is the children are the suffer, and AML adults are the affected. Okay. So this is another brain train of the patient presented to hospital with pancytopenia with leukemia. So pancytopenia, leukemia, polyphytic lymphadenopathy, and hepatosplenomegaly we can find out. So first question will be discussed with me, Dr. Sachma.
Yes, ma'am.
Yeah.
A 66-year-old woman is referred by her GP with anemia. She has been feeling generally unwell for past 3 weeks. Blood on admission show hemoglobin of 8.7 gram per deciliter, MCV 87 femtoliter, platelet 198, WBC count 5.3. Further tests were then ordered. Reticulocyte of 5.2%, direct antiglobulin test positive, IgG only, firm, film spherocytosis and reticulocytes. Okay. Which of the following is the most likely underlying cause? So,
So here direct antiglobulin tests are positive and films show there is a spherocyte and reticulocyte. So if I do the excluding method, cytomegalovirus infection is not accepted, right, Dr.
okay,
Sajma?
ma'am. Yes, yes,
Okay,
ma'am.
AML age is not according to the AML. AML is the young,
Young
it's a
age.
60, it's the elderly age, it is not accepted in my excluding method. CML
Okay.
CML age 66. In CML myelodysplasia, there is no point for the myelodysplasia. They said only cold hemoglobin test positive, spherocytes there. So for CML myelodysplasia, there is nothing in CML. Okay. Now
Okay.
mycoplasma pneumonia. For the mycoplasma pneumonia, for any infection, there is nothing, no clue. Okay. Now non-Hodgkin lymphoma. Hodgkin lymphoma, non-Hodgkin lymphoma, for the cold agglutination test positive, autoimmune hemolysis common, right? And the
Yes.
A is also common. So what is the answer?
Non-Hodgkin's lymphoma.
It's a non-Hodgkin lymphoma. Just if this question you don't know, if you do excluding method, the A is okay. Then AML is excluded. CML, there's no myelodysplasia, nothing. So it's a non-Hodgkin lymphoma because this is hemolysis ongoing. There's a reticulocyte, there's a spherocytes, there's an antiglobulin test positive. So all goes towards that is the lymphoma present. So cause it is the hemolysis. Okay, Dr. Sajma,
Yes, ma'am.
clear. Second question by Dr. Rita. Dr. Rita able to talk or not? Her voice from first and it's not audible. Yeah, read the question.
Yes, ma'am. A 17 years old man is investigated after the bleed excessively following a tooth extraction. The following results are obtained. Platelet 173, PT 12.9 seconds, APTT 84 seconds. Which clotting factor is most likely to be deficient? Factor 6, factor 7, factor 8, factor 9, factor 10. Ma'am, my answer is factor 8.
Yeah, excellent. It's the factor 8 cause why? Because APTT high, right? And
PTT is higher.
yeah, and there's a tooth extraction, there's a bleeding. So it's a factor 8. Why not 9?
Uh,
90% case is the hemophilia A, so it's a 8, but for the 9, patient commonly is not associated with tooth extraction. Though APTT will be high, but there will be the factor 9 deficiency, right?
yes, ma'am. Okay. Thank you.
Doctor, yeah, thank you. Dr. Sasma's case, autoimmune hemolytic anemia caused by non-Hodgkin lymphoma. Dr. Sasma, for you. Non-Hodgkin lymphoma cause autoimmune hemolytic anemia. Schistocyte positive, there's reticulocyte positive. So it's the non-Hodgkin lymphoma. This is the pearl for the hematology. Okay. Anemia in pregnancy, first trimester acceptable is the 11, second trimester acceptable is the 10, and postpartum acceptable is the below 10. CML and CLL case, so Dr. Saspa's case, CLL will be more than 60. There will be segmented enlarged lymphocyte bleeding due to thrombocytopenia, anemia, FBC show B cell lymphocytes, so all are the CLL. CML is only 50. There will be phylalia chromosome is the 922, and in CLL there will be mast cell. So in CML there will be the massive splenomegaly, leukocytosis, hyperviscosity syndrome, and the treatment is the imatinib. So remember CML, CLL, I just posted high yield exam point. First question will discuss with me Dr. Priya.
Good afternoon, ma'am. A 48-year-old man is diagnosed with acute myeloid leukemias and cytogenic are performed. Which one of the following is associated most with a poor prognosis? The lesions of chromosome 5, translocation between chromosome 15 and 17, deletions of chromosome 15, translocation between chromosome 9 and 14, deletions of chromosome 8.
So here your case is the acute myeloid
Myeloid
leukemia,
leukemia.
AML, AML. So ML chromosome will be the ML chromosome deficiency will be the which chromosome? 5 and 7.
5 and
So
7.
if 5 and 7, so if 5 and 7 deletions, the prognosis is not good. So what is the answer?
A deletion of chromosome 5, ma'am.
Yeah, its the answer is deletion of chromosome 5. And 5 and 7, just remember strongly,
Yes,
these
ma'am.
are the deletion which associated with acute myeloid leukemia. If this is deletion, so it is the poor prognosis. Thank you, doctor.
Thank you, ma'am.
Second question will be discussed with me. Very nice question, exam question. Dr. Fatima able to talk? Okay. Okay. Then this question will be discussed with me, Dr. Ikra.
Yes, ma'am. A 21-year-old man comes for review. He recently had an abdominal ultrasound for episodic right upper quadrant pain, which demonstrate gallstones. A full blood count was also ordered, which was reported as HB 9.8, MCV 91, platelets 177, WBC is 5.3. The patient also mentioned that his father had splenectomy at the age of 30. Which one of the following test is most likely to be diagnostic? Hamster's PSA staining of erythrocytes, glucose 6-phosphate dehydrogenase level, osmotic fragility test, and direct Coombs test. Ma'am, I think it's uh, glucose 6-phosphate dehydrogenase deficiency.
First of all, doctor, you have to understand the question. So say, already said that my father has splenectomy.
Yes,
Okay.
ma'am. Yes.
So father means it is autosomal. It's autosomal dominant. Dominant. So GCPD deficiency are the recessive. Okay. So
Yeah.
if we say this is the gallstone, remember gallstone only one point. Demonstrated gallstone. Is it GCPD or hereditary spherocytosis?
Ma'am, hereditary spherocytosis, osmotic fragility test.
Yeah. Clear?
Yes, ma'am. Yes, ma'am.
So spherocytosis evidence of the normocytic anemia, gallstone, family history. So it's a hereditary spherocytosis. Thank you, Dr. Ikra. So CML disorder, polycythemia vera, essential thrombocytopenia, CML patient presented with you hospital with granulocytosis, mesospleenomegaly patient, PH chromosome, myelofibrosis present with the B symptoms. B symptoms are the what? B symptoms are the night sweat, weight loss. These are the B symptoms. Thirsty, anemia, myelofibrosis, hepatosplenomegaly. These are the myelofibrosis presentation. Polycythemia presentation will be the hematocrit will be the higher. Erythromelalgia will be the higher. Itching. There will be the thrombosis and bleeding. Essential thrombocytopenia, there will be the thrombosis and bleeding, and there will be the high platelet count. Lymphoma. So lymphoma, it could be the Hodgkin and non-Hodgkin. So lymphoma B symptoms: unexplained weight loss, fever, night sweat, fatigue. For Hodgkin lymphoma, bimodal distribution age 25 to 55. It is associated with Epstein-Barr virus infection, red Sternberg cell. This is the exam question, my heart candidates. Red Sternberg cell will be the positive. And respiratory immunosuppression. Smoking treatment is the chemotherapy based on the histological and staging. We have to give the chemotherapy. Mainly remember, chemotherapy is the answer for the treatment purpose. Non-Hodgkin lymphoma, I discussed with Dr. Salsma maybe. So non-Hodgkin lymphoma associated with the hemolysis, so bone marrow infiltration with the cytopenia, extranodal presentation. Extranodal means hemolysis. B symptoms will be present, and there is absent red stern blood. So non-Hodgkin, absent red stern blood cell. So these are the brain trainer. Dr. Sajma will perform this case.
Okay, ma'am.
Okay.
A patient with HIV presents with painless peripheral lymphadenopathy, fever, night sweats, weight loss, and splenomegaly. What is the most likely diagnosis? Ma'am, the symptoms suggest lymphoma. It can be fever, drenching night sweats, non-Hodgkin lymphoma.
Yeah, it's a non-Hodgkin lymphoma, right? Because why? Patient immunosuppressant, patient HIV patient, and there is a B symptom and there is a splenomegaly. It's a non-Hodgkin lymphoma. But for the Hodgkin, there will be the red eastern blood cell will be the positive. There will be the Epstein-Barr virus infection. But your case was only HIV patient. So B symptoms for both, but the associated presentation immunosuppressant smoker is for the Hodgkin. For the non-Hodgkin, we have to remember extranodal presentation. Okay, doctor?
Okay, ma'am.
Yeah. First question. No, not first question, second question. Second question will be discussed with me, doctor. Second question will be discussed with Dr. Nandini Sharma.
Good evening, ma'am. 29 years old woman complains of tiredness, especially during activity. On examination, the patient appears pale. Ear nodes and cystocytes can be seen on the peripheral blood smear. The patient is referred for the bone marrow biopsy, and extracted cells are sent for cytogenic analysis. The most likely results are uh, ma'am, it's T922 because of the presence of ear nodes and cystocytes. It's AML.
It's AML. It's AML, right?
Yes, ma'am.
So for AML, is it, what is the answer? For AML, you diagnosed right, but your answer is not right.
Answer is not right.
What is your answer? I didn't hear.
Is it C T922?
No. For AML, T922 for the CML.
Okay, for CML. Okay.
T92, 922. For the AML,
is it a
it's
B?
a
B?
Yeah, it's a B. Yeah, it's a B. For
17.
AML, it's a B. Yeah. It's a AMC. It's a 922 for the CML. For the AML, it's a 1570 for the AML. Okay, doctor?
Okay, ma'am.
Barker's lymphoma, 814 Epstein-Barr virus. This is the, just they asked from the AML, CML, and just noted those points. Warfarin INR management everyday exam question. If INR 8, we have to stop and we have to give IV vitamin K1. Okay. If it is 6, we have to stop and we have to restart when it is below 5. So INR 6. If it is 5, we have to stop or we have to reduce the dose and we have to start the warfarin if it is below 5. If above or target range reduce or omit, we can do recheck INR 2 to 3 days later, major bleeding, stop warfarin, give vitamin K. My dear DHA had every candidate remember INR level. If it is 5 to 6 or it is 2 to 3, we can stop the dose. There is a bleeding. If it is severe bleeding, we give vitamin KIV, prothrombin complex concentration, and if unavailable, if it is FFP. Both questions they ask in the exam. ITP I discussed with Dr. Umesh Shahzad. Platelet will be low. There was the mucosa bleeding, there's easy bruising, epistasis. So in child, there was the acute and where the virus prodromal, and in adult, there will be the chronic non-viral prodromal. So in presentation and the treatment is the status and immunoglobulin according to the presentation. TTP I already discussed is Adams 2013 will be the deficiency, and there will be the low platelet, there is the elevated LDH creatine due to the deficiency. So management is plasma exchange and status according to the presentation. Polycythemia rubra vera very important for the exam. Patient present to your hospital through writers, fatigue, splenomegaly, burning sensation, headache, and the investigation with the JAK2 mutation and low erythropoietin hypercellularity is intermittent. And management will be the intermittent low long phlebotomy. Very important. They ask the presentation, what is the diagnosis? So diagnosis is the polycythemia rubra vera cause. There is a proliferation of the RBC, WC, and platelet. And there will be JAK2 mutation, direct question, DHA candidates, direct question, polycythemia rubra vera, direct investigation is the JAK2 mutation, low erythropoietin, hypercellularity, and we have to investigate and we have to give treatment, low dose aspirin and chemotherapy, hydroxycobalamin and interferon. Warfarin and surgery, anticoagulation, breathing. How we manage? We have to do the chart first in atrial fibrillation patient. We have to start the NUAC therapy, apixaban, warfarin, according to the management. Even before surgery, we have to stop this NUAC, this warfarin, and we have to do the breathing for the thromboembolism, and we have to do this management. So chart first score if any patient atrial fibrillation. So few question and the last question for discussion today. First question will be discussed today with me, Dr. Saba. I didn't see her till my session ended. She can participate
Yes, ma'am.
even she can do the wrong. Yeah, I didn't see till my session. So first question.
A 62-year-old man presents with a lethargy. A full blood count is taken and is reported as follows: HP 10.2 and platelet 330, WBC 15.2, film leukocyte erythroblastic picture, tear drop,
Teardrop, yeah. Poikilocytes, teardrop, poikilocytes. It's easy
and
question.
what is the most likely diagnosis? Number A, myelodysplasia, chronic lymphocytic leukemia. Number C, myelofibrosis. D, chronic myeloid leukemia. E, post-splenectomy. Ma'am, his HB is 10.2 and platelets 330, WBC 15.2.
Another important clue is there's a teardrop poikilocyte.
Yes, ma'am. The most important is teardrop poikilocytes. So, ma'am, it is
Thrombocytopenia, leukopenia, all are there. Only there's a platelet count normal, but there's leukopenia. It's the 15 also.
mhm. Ma'am, it is chronic myeloid leukemia.
Chronic myeloid leukemia we will not find out in teardrop. Okay, but it's a myeloid problem, but it's not CML.
Yes, ma'am.
Problem on myeloid, but it is not CML. It is.
So, myelodysplasia?
It's a myelodysplasia. It's a myelofibrosis. Teardrop poikilocytes for the myelofibrosis. Okay. Okay, doctor. Okay. You join later. That's why it's okay. You didn't hear everything. Thank you.
Ma'am,
No
I
issue.
just recently joined.
Yeah. That's the last question for today's session, and this is the last question and last discussion. Last question will be discussed with me, doctor. Okay, so Dr. Hira. Dr. Hira?
Yes, ma'am. A
Yeah.
24 years old nulliparous female with history of recurrent deep venous thrombosis, present with shortness of breath. The full blood count and clotting screening reveals the following results. HB 12.4 grams per DL, platelet 137, WBC count 7.5, PT 14 seconds, APTT 46 seconds. What is the most likely underlying diagnosis? Third generation oral contraceptive pill use, protein C deficiency, antithrombin T deficiency, antiphospholipid syndrome, activated protein C deficiency. Recurrent deep venous thrombosis.
APTT high. Your case, APTT high, and
Pretty
it's a
high.
female. Huh? Female case,
Yes, ma'am.
APTT high, recurrent. Listen very carefully. Exam question. Recurrent DVT.
Yes,
Recurrent
ma'am.
DVT and clotting revealed APTT high. So what is the
My
diagnosis?
antiphospholipid syndrome.
Yeah, excellent. It's the antiphospholipid syndrome. Excellent. Recurrent is the antiphospholipid syndrome. Thank you. So, Dr. Saba's case, myelofibrosis was the answer. Teardrop appearance. My heart candidates, listen very carefully. Myelofibrosis, teardrop appearance, exam question. Just listen carefully. Thrombocytopenia, leukopenia, and there is a progressive disease. So it's a myelofibrosis. And Dr. Hira case is a antiphospholipid syndrome. Thank you, doctors. Today my session summarize and concise every question, everything very important, and just highlight this question, highlight this point for hematology. Okay, inshallah all will be covered. Thank you, my dear candidates. Assalamu alaikum to all.
Thank you so much, ma'am. Love this.
Thank you, ma'am.
Thank you, ma'am.